Hello and welcome to The Wire. My name is Banjot. Today I have with me Professor Priya Abraham, the Director of Apex Research Institute of India, National Institute of Virology, which you all know is based in Pune. NIV played a key role in guiding the research interests of India when COVID struck and is also now anchoring the research efforts of India when monkeypox has come. With Dr. Abraham, I'll try to speak on both of these issues. This interview will be divided into two parts. In the first part, I'll try to discuss with her the situation on monkeypox, and in the second half, we'll discuss about COVID. Welcome, Professor Abraham. Thank you for taking out time for talking to us.
Thank you for having me on this.
Uh, as you know, Professor Abraham, 10 cases of monkeypox have been detected in India so far, 5 each in Delhi and in Kerala. Is it a mere coincidence that we had cases only in these two states, or maybe science can explain it better, either because of testing bias or due to some other reasons?
Well, it's a bit of lot of things. The fact that we have cases in Kerala is because all these cases actually came down from the Middle East, different countries in the Middle East. And as you know, a lot of our Indians do work and visit the Middle East often. So when they came down to India, and of course, the first case, of course, was very symptomatic and very, self divulgent that he has these cases and he wanted to be screened and wanted to rule out or know whether it is monkeypox. So there is, in a sense, a bias there because all these people, many people from the state of Kerala work in the Middle East and they come back, to their home state. So that's why Kerala, it's not because Kerala is churning out monkeypox cases, but many of the people who came down from the Middle East came in with this infection and came into their home state. In Delhi, that's difficult to explain, but it's a metro. But the cases in Delhi were not associated with travel, actually. It's a metro, it's a big city. Many of our big cities are melting pots. So we have people with different, backgrounds, different lifestyles. So I would say that it was Delhi, to me, is a bit of a coincidence. And of course, Delhi is has one of our trained labs there, as well as the headquarters of NCDCs there. But we have a trained lab there that is ready to kick off the testing and get it confirmed in NIV. So I guess that's more of a coincidence. The other is because the clustering from Kerala is because many of these people came out from the Middle East. That's the commonality there.
Just to take this answer ahead, is it also a possibility that since more of testing is happening perhaps at these two places and less of testing perhaps in other places, that may also be the reason that has caused some sort of bias, and therefore we are seeing cases only in these two states and not anywhere else?
For Kerala, I would say because they have had health issues in the past. Nipah, as you know, last year they had Zika. And the state of Kerala is very well, revved up to pick up some new infection, I should say. So, yes, they are a little more vigilant than an average Indian state. And we also have a field unit in Kerala. So, yes, maybe testing and, notification happened a little faster. With regard to Delhi, I should say that testing is being done in other parts of the country as well. In fact, including NCDC and us, we became 20 centers that could do monkeypox testing. Subsequently, we have tested another 12 centers. So on the cards, we have 32 labs that are geared for doing monkeypox testing. So this kind of clustering could have come from any other metro, in my reckoning. It just happened to be Delhi.
Okay. Can you give any idea as to how many samples we have tested so far for monkeypox?
The count is about 259 or so. haven't got today's tally, but it's as of yesterday was 259, out of which we had 10 positives.
And are we testing all first line and second line contacts of confirmed cases?
We attempted to do that in the beginning, and we did not get positivity in any of the first line primary contacts and some of the secondary contacts. No, we did not get positivity in any of them.
So can we say that none of the contacts of these confirmed cases have tested positive so far, and all are, new cases, unrelated cases unto themselves?
Yes, they are unrelated unto themselves in each of the 10, that's right. And we have not been able to detect by laboratory confirmation any transmission from each one of them.
And have we been able to trace the index case so far?
That's a difficult one because some of them came in from overseas. The Delhi cluster also, we don't know who the index case is. Some of them were in gatherings, and so that is a little more difficult. And also we must understand the current epidemiology and how it's transmitting. So getting an index case may not be that easy as, any other infection like a chicken pox, something
Right.
like that.
So, as you said that all these 10 cases are unrelated to each other. So, can we understand that, since these are unrelated to each other, so the virus is actually transmitting, it may not be converted into cases because we have only 10 detected cases, but the transmission of virus is actually there.
Yes, definitely. There is transmission happening, and they've got it from a primary index case. And we don't know, beyond the index case, whether they got it from another source. We don't have information, and we have not been given that information. But definitely the virus is transmitting, but not the kind of transmission that we have seen with SARS-CoV-2.
Right. And as you explained, we have 32 centers doing tests for, monkeypox viruses. Are they like, scattered all over India, or they are in certain geographies where samples have to be, transferred? And how does this work out?
They have come from different states in India because, once monkeypox came to be known as the latest outbreak globally, whenever a person's present either to the dermatologist or a physician, any private practitioner with eruptions, obviously that's something that is going to go through their minds. So we have got referrals from all different parts of the country. And one of the common differential diagnosis, when we say something that mimics monkeypox, has been chicken pox, or what we call varicella zoster virus infection. And in some children, we also got a hand, foot, and mouth disease. It's caused by an enterovirus. And I think in one case, I think we got herpes. So these can be mimickers of monkeypox. So we have actually taken the effort to train these labs also in the mimickers of monkeypox. So we've given them reagents and equipped them to rule out if it's monkeypox negative, what could it be? So they could at least test out the most common possibilities of what it could be.
Right. If you can also, explain that, because in the initial days of COVID, we saw that, the fact that samples had to reach NIV or such designated lab itself was a challenge. The transferring of samples was a challenge because those were very initial days of COVID. Did you face these challenges during monkeypox as well? Is it still a bit of a challenge to get samples in right quality and right quantity from the states?
I think if you look back at COVID and look at what we faced with monkeypox, it was relatively smooth, because now I think even airline carriers, etc., are, tuned to these category of reagents that are being, transported. So we did not have too many issues with, a leakage or small quantities or, them coming in too late for that matter. Now I think even the companies that do the shipment know how to go about the job, transporting clinical material to a reference laboratory.
One more question on testing. Could you explain what is the protocol for kits validation? Have we developed the kits validation protocol? If somebody has developed a kit, what's the protocol in that
So
respect?
NIV has developed a kit validation protocol, and they looked at several panels of clinical specimens from different sites. Then positivity of different levels, negative samples that mimic monkeypox, like I just mentioned, chickenpox virus, herpes, rubella. Wherever we could sample specimens with individuals with rash, we have taken those samples which are positive for viruses that mimic a monkeypox-like picture, made a panel, run it in several replicates, and then our findings were shared with the national committee that was appointed to look at the data and to vet it and to give any suggestions that in our creation of the panel. All that was done. And it was perfect timing, because by then the expression of interest that was floated by ICMR, that the time period had come to a close, and then just few days ago we met with the companies, and some companies have been shortlisted. So we're really ready to start the validation now. The companies that have been shortlisted will go through a typical protocol with a classical panel to validate the assay that they present for, which later would be given to DCGI for scrutiny, and then they can get their license to market in
And
the country.
that protocol is available in public domain.
The protocol that we used, no, we have not put it in public domain. We have shared it with ICMR and the National Committee, who we actually, we had it was a video call where, we presented each and every stage of our steps to validation. So that's been vetted by a committee, ICMR, and we are good to go.
Okay. If a physician or a dermatologist, as you said, finds something amiss, and he or she wants to recommend a test, so what is the sequence of events? Where does the person go to give the samples? And if you could explain the whole chain of events.
That's a very good question. So if I am a general practitioner or dermatologist or a small town physician, the best would be to inform these IDSP, the Integrated Disease and Surveillance Program Officer. We have a state surveillance officer, to inform them, and they will immediately take care of helping with getting that sample collected and taken to the nearest testing lab.
Okay.
But having said that, some clinicians and clinics do know that they have a testing lab in their city or in their state. So, for instance, in Pune, they are not coming through the IDSP. Many of them know we are here in NIV-Pune, and the samples are coming straight to us. So we typically ask them to give all the clinical features, and also send in photographs of the lesions, protecting the identity of the individual. We do not want to know the identity, but just the lesions, so that, if we get a better understanding how monkeypox lesions, vary. Some can look at a crusted stage, some can be very early stage, some can be papular, some can be pustular. And as I said, there are mimickers of monkeypox. So to make that diagnosis very comprehensive, we ask them to share pictures of the lesions alone, protecting the identity of the infected individual.
Right. So just to kind of clarify, if I, for example, is recommended, if I'm asked to undergo a test, so I have to contact the state IDSP officer.
You don't have to. The lab, the clinic, or the hospital that is wanting you to get tested, they contact the IDSP officer,
Okay.
Or if that particular hospital does know the nearest testing lab of these 32 labs, they can refer straight away. They all the numbers and the contact people are there on the Ministry of Health monkeypox guideline document, and that's in the public domain.
Right.
So name and number is there. So people can even call, take that number, call in and say, we have a suspect case. And then they are dialoguing with the referring clinician so that, samples are brought quickly, efficiently. And also if there is any, should they have any doubts about packaging, even packaging, all of that is there on the guidelines.
So essentially, the suspect patient doesn't have a role in this.
No, it's a
The
referring
patient is
clinician.
supposed to get a call from either the IDSP or the lab, for example, you said,
Yes.
and then the lab or the IDSP official will collect the sample. The patient doesn't himself or herself has to go to a lab, right?
Not necessary. No, they don't have to come to the lab. Not at all. We are not
No,
expecting
I
any.
mean to say any testing lab also, diagnostic lab.
No. It is between the clinician or the IDSP and the testing lab.
And no private lab is allowed to do monkeypox test at this point in
At
time.
this point in time, no, because it's only these 32 labs. But as and when we give, go signal to any of these companies that have, come forward with testing, then I think, we will have to broaden that base, because if we have some companies that have good kits, then we will be in a position to take a call. Even in COVID, it was a very graded way of, recruiting more and more labs, including private institutions, for testing.
Okay. One death has occurred, monkeypox death. The patient had returned from UAE and he died. He had no classical symptoms, as much as I understand, of monkeypox, and the doctors who were treating him got to know about his monkeypox status only after he died, just because he had tested in UAE before, coming back. Uh, is my two questions in this context are: was that patient asymptomatic to that extent, and therefore may be rare, but asymptomatic deaths are possible in case of monkeypox. Or there are some classics, or there are some symptoms which are not so very classic, but yet they were there. For example, encephalitis, which went sort of unnoticed, and the patient died.
So one thing is, first of all, there was no divulgence that he was monkeypox positive, which he tested positive for in UAE before he came in. And he had a kind of atypical presentation. There was a single healed lesion in his, genitals. And that also is disputable. Some people say they saw it, meaning managing clinicians observed it. Some people say it was not there. But he did have an enlarged lymph node, which had sort of become very pustular, and so he actually went to a surgeon, because he didn't come with the typical presentation of those typical lesions, though he knew he had the report, and the report was divulged by his family members only after he passed away. So when he comes with a surgical problem of an enlarged lymph node, which is bursting open, and disputable lesion in his genital region, it is something you would be thinking of other possibilities initially. Physicians would be thinking of other. In fact, he went to a surgeon, didn't come to a dermatologist or a classical ID physician. And then, of course, he came back because he started becoming worsening in his conscious state, and then he became comatose because of his encephalitis. So in 5 to 6 days, he was then on intubator, and then we lost him. So this is a very atypical presentation of monkeypox. Though there are other presentations, totally, as far as I know, with this massive global outbreak, there are about 10 cases, most of them from Africa, and 4 from outside of Africa, as far as I know. And that makes it about 0.02%.
Right. No, just because say like he went to a surgeon and he did not go to a dermatologist or an infectious diseases physician, ID physician. Uh, a patient might actually not be knowing, whom to go to. So, for the sake of common viewers, they might not be able to apply their mind, which specialty is the best specialty for them to approach, and this may repeat in future also. What perhaps you would suggest, maybe to doctors or to
I
the
think this
patients?
is a very atypical presentation, which should not become something that is alarm causing.
Mhm.
But I guess all physicians, all healthcare workers need to keep this differential diagnosis in their mind. I do not blame the fact that he landed up with a physician, a surgeon, because that's the kind of typical lesion. You have an enlarged mass, which is almost become pustular, going to dehisce. You would tend to go to a surgeon
Right.
if monkeypox was not around.
Right.
So I think I would um, not like to give too much importance to this kind of presentation because it's really atypical. And I think this would be alarm causing for the general public. But I think it is more a matter of a kind of unusual case, which doctors and healthcare workers need to keep at the back of their mind without alarming the public. Because
Uh,
that kind of presentation could be a mimicker of many other things.
mhm.
It could be any other sexual transmitted disease. It could be just an abscess somewhere there. They could have had an insect bite that got infected. It could be so many other things.
Mhm.
It can sometimes even TB can present like that, tuberculosis. So, to say that if you have a lump in your groin and, it's enlarging, that has to be monkeypox, would be a bit of a stretch for me. But it's good, as I said time and time again, for healthcare workers to keep this in the back of their mind.
Just taking from your answer, this requires perhaps a massive awareness or training for doctors also.
I
And we
think
saw this during COVID, that government did use some, did organize some programs, virtual and otherwise, mostly virtual, of course. Has any training or programs been planned so far for doctors? Because what I gather from your answers, I mean, diagnosing symptoms or suspecting a case is going to be really, really important.
I think that has happened. In fact, the picking up of the initial cases in Kerala, typically, when you have an infection, you go to an infectious disease person. But the first case went to a dermatologist. And the dermatologist picked it up and alerted the infectious disease. So I would say Kerala is very tuned to it because they've been at the they've gone through several crises in the last few years with different novel kind of infections. So they are very proactive. But having said that, in many of the clinical, clinicians fora, they are having training among the clinicians how to pick up monkeypox, what is the typical presentation, what are the possible atypical presentations.
And such trainings are being organized by government outside Kerala.
Yeah, maybe state, maybe academic bodies.
Mhm.
They may be doing it. I'm not aware. I really do not have the answer of how many trainings and where and when. But I am very aware because even the Ministry of Health and Family Welfare was very quick to put out that guidelines so that that's a document. And in fact, we sat and revised it also. We had where we went back to the document and spit polished it a little more based on the experience with the initial cases. So information is out there. I know interaction and training is happening among clinicians, but I can't give you more information as to when and how many people have been trained. I don't know.
Okay. Uh, about vaccines and the drug tecovirimat for monkeypox. So there has been almost a consensus and a view amongst experts that at least the contacts of the confirmed cases should be vaccinated. Has there been a discussion on this, and is government thinking about vaccinating the contacts?
I think there is some discussion about trying to procure the highly attenuated vaccine from Bavarian Nordic. It's called using the modified Vaccinia Ankara strain. So it's abbreviated as an MVABN, modified Vaccinia Ankara strain, which is made by Bavarian Nordic. It's a highly attenuated version of the Vaccinia virus. So there is some talk at the governmental level about procuring it. I don't know how far they have gone with that. And thus far, Ticovirimat not yet officially licensed for use in our country. And I really don't know whether the government is yet taking very definite steps to stockpile the drug. As you know, in many other nations, it's now become very territorial. People are taking, vaccine doses, making sure they have a very good stockpile of vaccine doses and antiviral drugs. But I'm sure India will be doing something very soon in that direction.
And from science perspective, you think that it would be a good move if finally this is decided to vaccinate the contacts of the confirmed cases?
I think it it's a good idea, but there are many other approaches to try and contain an infection. We know how mostly it has been transmitting this time. So if we educate individuals who have been declared to be a confirmed positive, and anyway they go into isolation, but even if they have been contacts of a known case, the document actually advises that if an individual has been a contact of a known case, they should also, be practicing safe sex, barrier protection, etc., so that they could not be, if they have picked up the infection and they could be in the incubation period for the next 21 days, that they should be careful that they are not transmitting this infection should they be an infected asymptomatic individual.
Right. Uh, this takes us to the second part of the interview on COVID-19.
Yes.
Uh, there has been a small uptick in cases, and not just in cases. In fact, there has been a small rise in hospitalization numbers as well. Deaths also have gone up by a small margin. What do we make of this rise in COVID cases once again?
Um, we know there's a lot of transmission that is happening. A proportion are asymptomatic. Many people are not getting themselves tested. At best, they use a home-based test, which is good if you have high virus loads and you're symptomatic. If you're early in the course of infection or you're asymptomatic, you could actually come out false negative using that device, and you could still transmit the infection. So transmission is happening all over the world. So when more transmission happens, there are more individuals getting infected. And when that denominator swells, then the numerator will also marginally increase for those who can develop serious disease, requiring hospitalization and very rarely death. This is happening mostly in individuals who have some comorbidities or they are partially immunized. It is in that category of group of individuals that they are likely to, have a very adverse outcome. But if you look,
please carry on.
Yes, but if you look at the vast, if you look at the actual denominator, that numerator is very minuscule. And, when the denominator swells, that numerator of seriously, those having serious COVID-19 will also swell a little bit.
Right.
Because there are a body of people who would, not handle COVID as well as a young person, or who doesn't have any other comorbidities, or who's completely vaccinated, for instance.
I'm not inclined to call it any third, fourth, or fifth wave, but do you reckon that this is a rise in numbers, and this is not something as similar to what we were seeing, a kind of flat graph? We can clearly see a rise. So do you reckon that yes, this is a rise in numbers, but it will be scientifically not prudent to call it fourth, fifth, or sixth wave, whatever?
I think we should not call them waves because these little peaks are going to happen ever so often. And we see it in different parts of the globe. We heard China, Hong Kong, a few months ago had a surge in cases. UK had a surge in cases. US had a surge in cases. Australia had a surge, not though not so huge. And in India, we are also going to have periodic surges, and especially where, as if you see now, people have taken back to travel. Everybody's holidaying, and we're coming into festival season. People are, don't want to, continue in COVID mode. There is that COVID precaution based fatigue, which people, are kind of burdened with. So we will be seeing surges. I wouldn't like to call them waves because surges will happen, they will ebb away, they'll come, they'll go, and that is going to be the scenario.
Right. And could you say what is the dominant subvariant of a lineage of a subvariant, or if there is any new variant that is causing this small surge, as you say, in India specifically?
The dominant variant is again a subvariant of the Omicron. They are both BA.2.75, BA.2.76. In India, we have a lot more of BA.2, but if you look at US, it's largely BA.5. So there's a lot of excitement, a lot of hype about BA.5.
Right.
Whereas we have more of BA.2.
You mean BA.2.75?
Yes, BA.2 and its sublineages. We'll
Right.
have also a lot of other,
Right.
cousins,
Right.
so to say, first cousins and second cousins.
Right.
So yes, we do have a lot of sublineages within BA.2, and that's the predominant one here.
Right.
As I said, in other countries, particularly in the US, it has been BA.5. That's the scenario.
So, if you could, for the sake of better understanding of our viewers, could say, how is BA.2.75 or other sublineages of BA.2 different from a previous, appearances of Omicron, if I may call them so, and also BA.5, which is currently dominant in US and other parts of the world?
So typically, I mean, it's a broad generalization, but when newer and newer variants emerge, they tend to be little more transmissible. That's the
Than the
trait
previous one.
than the ones that have come earlier. And they also, because they are facing the resistance of the immunity among those who have been vaccinated, who have or had had previous infection, they tend to become variants that can escape immunity to some extent. I wouldn't say they completely escape, but they can sort of slip away a little.
Right.
So there's some amount of immune escape, typically more transmissibility. Like for instance, if you look at BA.5, it's much, much more transmissible than the earlier subvariants. Also, it has got a higher level of antibody escape.
Yeah.
So that is the trait, because the virus is only...
And sorry to interrupt you, but what you said about BA.5, that it is more transmissible, it has a certain immune escape potential. Can we say same things about BA.2 and its sublineages, which are dominant in India?
Yeah, compared to the other BA.2 sublineages, these are little probably more transmissible, but not starkly so. And coming back to BA.5, a typical example of how the immunity immune escape could happen is that a person who has been vaccinated or recently infected with an earlier Omicron lineage could still pick up BA.5. Infection. I underline infection. There are two big differences between infection and disease.
Absolutely. So, for the sake of our viewers, I had to ask questions on which is the current most dominant variant, because INSACOG, the Genomics Consortium of India, used to put out weekly bulletins informing people at large what is the current dominant variant. But for reasons that is not known to us, there has been no bulletin since July, mid of the July. Here we have Dr. Abraham explaining to us that currently BA.2.75 and other sublineages of BA.2 are the dominant appearances of Omicron in India. And have we conducted any study, or are we in the process of conducting studies to understand what is the immune escape potential, how much more virulent they are, how much more transmissible they are? Are we conducting, because these BA.2.75 emerged, as I understand, in India only. So are we conducting these studies, or have we already conducted them, and if there are certain
Uh,
results that you could share?
we are not actually right now doing any studies of virulence. In fact, this was a BA.2 sublineage that, by the public database GISAID got
Right.
reclassified as BA.2.75, almost after it was submitted. So, because when all these subvariants with their specific amino acid mutations that are expressed, I mean, the nucleotide mutations that translate as amino acid changes, when these are analyzed, you realize, oh, it groups with that or it groups with this.
Mm-hmm.
I think there was little more hype about BA.2.75 more than it needed. In fact, now we have BA.2.76 also there. We are going to see new ones. That's a given. So I
Right.
think we should not get too distracted or unduly alarmed when
Mm-hmm.
we hear of a variant of a new kind of terminology.
Right.
We just need to realize that this is still COVID, and there are
Right.
still ways by which we could stay protected
Right.
and even protect ourselves from infection per se.
But do you think that we may need studies to be undertaken as more subvariants or sublineages emerge? Just to know that if our vaccines are working fine, or if virulence has certainly not become so strong. So by virulence, for the sake of our viewers, by virulence I mean the severity of disease caused by the newer appearance of Omicron. So
So
do you think somewhere we need to be doing these studies, or will be doing this in the future?
So we have been doing, and this is like you can never play catch up because the variants are coming one after the other. But we have been studying these variants, BA.1, BA.2, and then we've now got BA.5, and we do actually animal pathogenicity studies in golden hamsters.
Mm-hmm.
We do that. But they are, experiments where you have to grow up, make a standard titer of the virus, vaccinate the animal and see what it does, despite vaccination, what these variants can do. Without vaccination, what can these variants do? These take some time to generate and look at the immunological parameters in these artificially infected animals. We have been studying that. But if you ask me specifically about BA.2.75, we don't have any data about that yet.
Okay. As you said, that the virus will keep on evolving. In fact, that is perhaps the only way that it can survive, because a large part of our population has two jabs already, and they have got natural infection also. So the only way that virus can survive is to evolve into new, avatars, if I may call it so. So, the common understanding is that a newer subvariant or a newer variant would be less severe than the previous one. So, for example, we saw in the case of Omicron, Omicron itself, of course, vaccines played a role, but Omicron itself, now the studies say, was not capable of causing severe disease as much as Delta was capable of. So, can we say that the future variants or subvariants are going to be, milder to that extent, or we really can't say that, because when Delta emerged, Delta was, just wiped out everything else. Delta emerged to be stronger than the original wave, the form of the virus. So, if you could explain what to expect from variants, of course, we can't predict, but what to expect from variants or subvariants that will be coming up in future.
So your comments themselves were very, insightful. One is one would expect with the amount of vaccination and the amount of natural immunity to some extent in a population, that the subsequent variants that would emerge would be milder, would cause milder disease. But there is no hard and fast rule. We could never tell when a particular variant that has n number of mutations could lead to something that could be capable of causing a very virulent infection. We could not say that it's an impossibility. So that's why everybody says, you could just gaze into a crystal ball when you think about the future of COVID. But the former possibility is more likely, is the best guess that we can have.
And that is that we may not have
We might have
variants. Yeah.
milder versions of variants,
Mhm.
but I think it is not yet time to think that it can only get better and, the worst is over. We would like to believe that's the case, but I think we still should remain vigilant.
Right. A related question to this, since we are talking about variants and subvariants, do you have an idea that as to how many samples, COVID samples, we are sequencing every month in last couple of months? If you could throw
I
some light
think
on that.
to the tune of somewhere between 5,000 to 6,000 across the country. Because because we must remember that the main people we are sampling are those who are admitted to the hospital or seeking medical attention, and there is a surveillance of some of the incoming travelers.
Mhm.
And not with the kind of intensity when alpha variant came about, or when the news broke out of the beta variant or Omicron. So there is a background surveillance happening, which is to the tune of 5,000 to 6,000 samples collectively in India, which is what we are seeing over the last couple of months. And I do know that we should not, go laxer and reduce the number of sequences submitted per month to even lower than this. This is perhaps the bare minimum we need to do for a country that's so large and complex and which has so many airports and ports of entry. So I think this would be the minimum that a country like ours should do.
Right. So, we have historically seen, and this is historic data, some states are very kind of proactive in sending samples from genome sequencing, but some states have been historically very lax. And there is data to suggest so. Does that still continue? And do you still, kind of need to prod states that they also, especially the ones who are not sending enough samples, that they need to do more, and the worst is yet not behind us?
I think, of course, for any health index, there's no state that is, all states are not identical.
You still encounter this disparity among states, and you could say
That
that there are some.
disparity is not there that much. Because now it is so well covered. If you see the map of labs that are able to do whole genome sequencing, it is really well represented right into the Northeast, going up close to Jammu Kashmir. There are labs that can cover that area. So that disparity which we observed in early days when we were part of the original INSACOG consortium doesn't exist that much.
No, I fully agree with you on the fact that there are labs scattered almost everywhere in India which can do, genome sequencing. I am talking in terms of samples which the state governments have to send to these labs. What we have historically seen is that certain states have remained very lax in doing so. And this has, to an extent, frustrated scientists also, because then in that case, they do not get to know what the real situation on the ground is in terms of variants. So does that problem still exist with few states?
That's exactly what I was trying to say in the beginning, that states are never equal. And there are some states that are, super proactive.
Right.
And like Maharashtra, for instance, we have 4 labs in Pune that can do it. So
Hmm.
we all get flooded at a time
Hmm.
with samples.
Right.
And it's related to several factors, not just the medical colleges. It's also related to the state surveillance officer. Some are very, very proactive, some are mediocre. And also the general importance given to health. And there's so many factors. Some states are so heterogeneous in themselves. They are
Hmm.
big and very heterogeneous. So that has existed with virtually every aspect of health. So
Right.
that all are not exactly at the same level. No. But in terms of coverage, I'm not saying just that labs exist, but in terms of getting samples, it has improved a lot from what it was earlier. But
Okay.
there are some areas that are intensively, undergoing surveillance. Some are, not that
Not
so
so.
proactive. That will happen with every disease and
Right.
any state health issue.
So, what is your message to those states? It's
No, I
high
think
time.
that we meet at INSACOG, and that is being reviewed actually. Data gets reviewed from different states, and then that goes back to the NCDC, and the NCDC works to the IDSP to, sensitize, get in touch with the referral hospitals. So
Right.
that it's a very wide network
Mhm.
which needs to be constantly, what the machinery needs to be oiled and kept in
Right.
tune. So I
Right.
think the idea is this information is brought to the attention of NCDC. In fact,
Mhm.
during our INSACOG meetings that happen every week, that is brought to light. We've not got any data from this area, and then that's conveyed to NCDC, and they work through their IDSP network to, correct that. That is happening.
Okay. Now about masks. So, you know, as we saw cases going up, certain states, at least Delhi, brought something back, what is called mask mandate. So it is another thing that it is hardly being followed, but they brought it back. Now, we do know that masks still remain one of our most important tools in the box. But then mask, as you earlier spoke about pandemic fatigue, so mask fatigue is also a reality. uh, do you think that instead of bringing those mandates back, there was something else that any government, not just one particular state government, but any administrator could do to kind of find a common ground where you don't have to impose a mandate which he or she also knows will not be followed, and yet ensure that people wear masks at least in places where they are supposed to? So, do you think that mask mandates have actually, outlived their utility, and we need to innovate something else to ensure that masks are used?
I think, unfortunately, masks are perhaps one of the most effective tools to prevent infection. There's no getting away from that. And what I do when I travel in a plane and I find people sitting next to me where the mask is being worn at by the chin, or the mask is off the nose, I turn around and tell them the mask wearing is for your protection, not mine.
Right.
And then it sort of sinks in. It is for me. If I am getting into a situation where it's a crowded environment, it is a poorly ventilated setting, lots of people out there, some wearing masks, not wearing a mask, it should be a personal choice, and I think a sensible choice, and people should be made to feel that conviction on their own, that I want to stay protected, so let me wear masks. Like, for instance, recently we had some visitors who came from an overseas country. Now, if you see video images of many of the big cities in the world, nobody's wearing a
Hmm.
mask.
Yes.
But these visitors were all wearing a mask all the time while here visiting us. We didn't tell them.
Right.
And we wore a mask. As I mean, in the institute, everybody wears a mask. I'm here alone in a room, so I've taken my mask off. But if somebody were to step into the room, my mask is right here. I'll put
Right.
it on. It's just next to me. So I think what we need to communicate to people, yes, this mask is a real pain. And in festive times, when you want to look your best, your, weddings and whatever, the mask comes in the way of a lot of the fun and frolic. Even sometimes when people talk, you can't make out, and then they have to pull down their mask and speak. It is a spoiler. But given the fact that this virus is still around, people need to weigh the odds for themselves. So I never fail to tell at least two people in the plane, whom I can see in the vicinity, to say the mask is for you, not for anybody else. And you will see that they'll comply much better. They wear the mask for the rest of the flight.
And mask mandates work anymore?
Mask mandates, I think you'll have to make a sensible choice if you're out there in an open air ground.
No, I'm asking from point of view of an administrator. Of course, it's a pretty valid point that one has to wear a mask for his or her own protection. But I'm asking from the point of view of administration.
See, I think mask mandates, for a good administrator, he would use a mask mandate, in my personal opinion. But very often, this is striking a balance, with understanding that the public in the state are fatigued from this. And, people very delicately balance the situation and say, don't crowd, not so many people at a wedding, not so many people in the mandir. So people are striking a balance. We should actually communicate to them that the virus is still capable of transmission. So when you think you are in a situation where you're very close to a number of people who may or may not wearing a mask in a poorly ventilated room, masking should be, it's not a choice, is a must for your own protection.
My other question is also about messaging. So masks formed one part of the messaging, vaccination was the other part. Now, there is no doubt that the current set of vaccines are targeted only against hospitalization and death and not infection per se. We are in process of, the global scientific community is in process of making second generation vaccines. But currently what we have is only against hospitalization and death. But somehow, due to maybe ignorance or whatever other factor, people do intend to think that vaccines prevent against infection also. And somehow there is a false sense of, if I may call, absolute security that, oh, I have taken 2 jabs and I'm protected from everything, has kind of gone down into people. So do you think that we also went, as part of scientific community or as part of administrative messaging, this also happened that that we went overboard with vaccine significance, and now people are thinking that they have got the best solution and therefore they are not ready to take other precautionary messages, including what you stressed, masks?
So I think, yes, I feel our messaging should now come out loud and clear that these vaccines are vaccines for prevention of serious consequences or sequelae or complications of COVID-19. They do not serve to prevent against infection. In fact, most vaccines, they are meant to prevent disease,
Right.
where you could get sick and hospitalized. But the whole idea is, when you give a vaccine, should you get infected, you have an immune response to counter that. It's not that the virus won't come near you.
Right.
The virus can come near you because of the very way by which it transmits. It could get into your, through your nostrils, into your upper respiratory tract. Definitely will get in. So I think we need to say that you could still pick up the infection by its very nature of transmission, but the vaccine is a vaccine for preventing disease, that too serious forms of disease. I think we should message, see, the whole COVID pandemic, we have always learned how better we could do something. So I think that messaging should come through.
Thank you so much, Professor Abraham, for joining us. It was a pleasure talking to you. Thanks a lot.
It was nice chatting with you too.
Get a sneak peek of exclusive content before everyone else for channel members only. Memberships start at ₹89. Hit the join button below.